As you saw, we met, as I said, we met about 6 or 9 times on each of the unit, and that's not nearly enough meetings to change culture. So in terms of the ultimate outcomes, we've just started looking at those. We've looked at the AHRQ patient safety survey, and I can tell you that over a year in Hospital A, which is the only one where we've done a follow-up, the outcomes didn't move. If you had asked me the week before, I would have told you I didn't expect them to move because the intervention just isn't mature enough after meeting 6 or 9 times to change the culture. The other outcomes we're going to be examining are the nursing sensitive indicators and the NDNQI, some of the nursing work environment survey also. We haven't looked at those numbers yet, but again, even if they improve based on this logic model, I don't think our team is going to take credit for them. After another year of intervention and working with those units, we would revisit that idea. So I think the stage that we're at right now, okay, is to say that we think there's a promising intervention because it's changing the conversation that the front line has with the executive suite. It's bubbling up the daily problems to the attention, both where the nurses themselves know this happened 300 times on our unit this month, and no one's paying attention to it. But also getting attention from the folks that matter. So I'm going to turn it over to Kathleen, who will spend just a minute telling you what we have planned for follow-up in terms of funding and publications and dissemination.
Thank you, Bob. Dissemination then will begin with training our focus on sharing our preliminary findings. And I have to say that connecting with the mid-level management and giving feedback, reflecting on the words that were said about the first order problems, really buffered up the resolve of the mid-level managers from the indicators that they have, these numbers that we've produced, to thinking about it really is a problem and the nurses are expressing it and capturing it in their hour-by-hour report. So we've reported some of those at the Summer Institute on Evidence-Based Practice this past summer, and also at the Improvement Science Summit again this past summer. Our future audiences then begin to formulate around journals and dissemination channels for the administration and C-suite. Medical surgical nurses, I think this resonated with them. We saw some shifts, at least in our qualitative data, that they felt like they were now engaged in redesigning an entire unit. Wasn't a direct cause of the project. However, it was opportunistic that they then had a voice and thought that they could provide ways to resolve the issues, for example, with the dirty utility room. Quality improvement venues, interprofessional. I think one of the great seeds that's been planted by the Inquiry Project is the work that Dr. Freer and I have done ongoing for close to 10 years now. But this gave us an opportunity to share perspectives and to begin articulating, what does a practice-based research network mean in medicine versus in nursing? I mean, it's just the verbiage itself. And so moving into the acute care setting was quite interesting. We do hope as we get to a more solid triangulation of the qualitative and quantitative data to present this into the AHRQ Healthcare Innovations Exchange as an innovation that has some promise. So this is now the research that another seed that's been planted, and the research that we want to move forward with, of course, is a more intense intervention with the facilitator and also the spreading this. We have an N of essentially 6, because when you study microsystems, all of a sudden your sample size gets very, very small, although we have close to 800 nurses involved and interfaced with this project. We presented this as an improvement science research network study. In July, we launched this as a nationwide research project to build a research collaborative around. And we would drill down specifically on phase 1, looking at the pocket card study questions and the two hypothesis that Dr. Ferrer presented. And I'm laughing at myself because now, did I remember to go the right way? Yes. So I can learn on my feet. So the investigative team was very important. Besides our collaboration, we had medical anthropologist who is also at the UT Health Science Center and VA. And our research team is broadly based in terms of statistical support, masters in public health, and Amanda Sentes was our research associate and trained as our facilitator interventionist. Our hospital partners, we continue to develop that model of academic practice partnership. Thank you.